Great. So for the end of the lab meeting, we're going to transition into our journal club, and we have Sam Kraus, who is a fourth-year medical student doing an elective with us in the OB Motivate Clinic, who's going to present on a recent publication from the lab. And Sam, today was your first interview day, I think, right? And so congratulations.
Thank you. Yeah, it was the first day. I've still got my ring light set up and my whole interview space created still.
Well, thanks for leading our journal club tonight, even though I know you had residency interviews today.
No problem. Thanks everyone for having me. I know I'm a bit of a newbie when it comes to addiction medicine, and I'm sure that you guys are more well-versed in the literature than I am. But I thank you for your attention and inviting me to be here. So let me share my screen as well. All right. So the title of today's journal is A Need for and Receipt of Substance Use Disorder Treatment Among Adults by Gender in the United States. I see a couple other names here that were listed as authors as well. So thank you for all your work on this. So as I said, I know you guys are a little bit more well-versed in the literature and the background of the current state of addiction medicine, so I'll try to make this brief. In response to the overdose crisis happening in our country, the U.S. Department of Health and Human Services urged our country to increase access to substance use disorder resources, including prevention, treatment, and recovery systems. This call was first issued in 2017, which is now 4 full years ago. And at the time, there were as many as 20.7 million Americans suffering from substance use disorder, but only 4 million that actually received treatment. So less than 20% were receiving treatment at the time. Since then, many efforts have been made to combat the substance use epidemic in our country, and the demographics have started to shift. It's been well documented that although adult men are more likely to have an opiate use disorder compared to adult women, it appears that the opiate use epidemic is now preying on adult women in this country. In the last 10 years, the rate of OUD diagnosis and the number of overdose events has rapidly increased among women more than men, and deaths due to alcohol use has also disproportionately increased in women. Similarly, women have been shown to more rapidly progress from substance use to substance addiction more than men, and women tend to express more severe disease processes and tend to have more psychosocial comorbidities. With this emerging research about this disproportionate data, it's becoming more and more evident that we need more research on why these disparities are occurring so that our country can appropriately respond. So while it's been shown that women are not receiving treatment for OUD at the same rate as men, it has been shown that both men and women respond effectively when they are treated. This is good news for clinicians that show that our methods are working, but there's still quite a bit of work to be done to get those people into clinics in the first place. Historically, the literature suggested that women with substance use disorders were less likely than men to enter treatment, but more recent data is showing that the disparity between treatment receipt may have more to do with other variables, as this was not consistently shown across different racial and ethnic groups. More recent studies are showing that among groups that do experience a difference in substance use treatment receipt by gender, it's largely due to the larger number of barriers to treatment that women experience at a higher rate than men, including pregnancy and childcare responsibilities, stigma, psychiatric comorbidities, etc. With this emerging data, it's becoming more evident that public health strategies must be informed by these gender disparities and should aim to reduce these barriers to treatment that women suffer from disproportionately. Thus, this paper was born to help hopefully direct some of those responses. So the primary objective of this study was to report on the unmet needs and receipt of SUD treatment by gender and substance type, i.e. illicit drugs and alcohol, among people with a past year SUD using data from the National Survey on Drug Use and Health, or the NSDUH, from 2015 to 2018. And in doing so, this paper analyzed outcomes separately for OUD, given its increased attention as a result of the current opioid crisis. Secondary outcomes of the paper assess gender-specific sociodemographic factors associated with unmet SUD treatment need and reported barriers to SUD treatment. So how did the study examine these needs? The National Survey on Drug Use and Health, or the NSDUH, as I'll refer to it, is an annual survey of the US civilian population conducted using computer-assisted self-interviewing. It's emerged as a core source for epidemiologic data for behavioral health conditions and treatment, and it's often used in public health initiatives as a state and federal level. The study examined results from the NSDUH from 2015 to 2018, which resulted in over 170,000 respondents, which when weighted appropriately for the approximate 7.8% of people in this country experiencing SUD in the last year, it's about equivalent to surveying a population of about 246 million. The population of respondents included men and women aged 18 or older, and respondents were classified as having an SUD treatment need if they met criteria for having a substance use disorder or if they expressed a need for requiring treatment for SUD. Using DSM-4 criteria for dependence, respondents were classified as having an SUD if they met criteria for dependence for either alcohol or illicit drugs. Using data from the NSDUH did present some limitations, which I will discuss in more in depth later, but I wanted to mention here that the NSDUH only captures sex and gender as one variable, not as two separate variables that we hold to now, as with sex being a biologic construct and gender being a social construct. So as I mentioned men and women, I'm referring to how the respondent answered to that one checkbox question. The variables of interest for the study as defined by the primary and secondary outcomes were the receipt of SUD treatment and the barriers that those who did not receive treatment experienced. And those were stratified by gender and ethnicity. Receipt of SUD treatment was broadly defined and included treatment at a specialty clinic such as a rehab or a mental health center, or any other treatment location like a hospital or emergency department or a jail or prison anywhere else. The barriers to treatment were subclassified into the following categories: financial reasons, such as not being able to afford treatment or not having insurance or insurance that doesn't appropriately cover SUD treatment; transportation of time restraints; desired treatment not being available, or if they did have a desired treatment, it was full and or at capacity; having a negative opinion about treatment, such as thinking that the treatment wouldn't work or not even seeing a need for treatment; or concern about treatment affecting their job or reputation based off of stigma. Gender-specific data regarding past year SUD treatment need was evaluated using a Pearson-Chi test with P set to less than or equal to 0.05, and the sociodemographic factors were evaluated with multivariable regression as well. So what did this study discover? So on this table, I've highlighted a few important variables of discussion. Firstly, about 2/3 of the sample were identified as men and 1/3 were women. A majority of respondents identified as non-Latinx white, and they were employed, they had health insurance, were unmarried, and had at least completed a high school education. Compared to men, women were found to be younger, more likely to be unmarried, have government program assistance, and have comorbid depression, whereas men generally had a lower level of education, did not have health insurance, and were more likely to identify as Latinx. There's a greater than 4% difference between Latinx men and women with current SUD. This is a continuation of the same table of demographics I couldn't fit on one slide. Here you can see the difference of percentage of women that are parenting compared to men, which is more than a 7% difference, and the difference in comorbid depression. There's over a 13% difference between depression with SUD in men versus women. So 98.4% of the study population met DSM-4 criteria for having an SUD, but only 6.8% expressed a need for requiring treatment. Alcohol use disorder was the most prevalent SUD, as 74.5% needed treatment for alcohol use, and 35.4% of people needing treatment was for illicit drug use. Of this group, opiate use disorder was the most prevalent SUD regarding illicit drugs at 10.6% of the population. And when stratified by gender, women were found to have a higher rate of opioid use disorder at 11.9% of women compared to only 9.9% of men. This was the only substance use disorder found to have statistically significant difference between men and women. Not shown in this table, it was found that a greater percentage of adults with OUD needed treatment for pain relievers rather than for heroin use. About 10% of women and 8% of men use pain relievers compared to about 3% of men and women using heroin. About 1 in 10 people received treatment for SUD, and this treatment receipt did not significantly vary by gender. It was found that a higher percentage of people needing treatment for OUD received treatment compared to alcohol use disorder, as 1 in 3 people who had OUD received treatment compared to 1 in 12 of those requiring treatment for alcohol use. This also did not statistically differ by gender. Regarding the secondary objectives of gender-specific sociodemographic factors pertaining to receipt of SUD treatment, it was found that expressing a need for treatment was not associated with actually receiving treatment for SUD, as the adjusted odds ratio confidence interval for both men and women contained 1 and was found to be statistically insignificant. Race was a very important factor in whether or not one received treatment, as Black women had a 49% less odds to receive treatment compared to white women, and Black men had 56% less odds of not receiving treatment compared to white men. Considering all racial groups and gender groups, Latinx women had the lowest odds of all to receive treatment with an adjusted odds ratio of 0.37. Having private health insurance was found to increase the odds of receiving treatment for SUD among men with an adjusted odds ratio of 2.05, but not among women. It was insignificant. Interestingly, men with lower incomes had an increased odds of receiving treatment compared to men with higher incomes with an odds ratio of 1.76, but this was not observed to be true among women. Another interesting discovery was that parenting women exhibited higher odds of receiving treatment compared to non-parenting women at odds ratio of 1.97. The other secondary objective was to evaluate barriers of treatment among those who expressed needing SUD treatment but did not receive it. This figure was not included in the paper, but Dr. Martin sent it to me, and I thought it was important enough to include in the presentation today. The study found that over 90% of those that expressed a need for treatment but did not receive it reported at least one barrier. And the top 3 most common reported barriers were a negative opinion of treatment at about 58%, followed by financial reasons around 37%, and the desired treatment being unavailable or at full capacity, about 26%. Women were found to be significantly more likely to report transportation and time commitment barriers than men. About 24% of women reported this compared to 9% of men, as well as having more worry about the effects that the treatment may have on their reputation. About a third of women were concerned about the stigma and 17% of men. These patterns remained nearly true across the board when controlled for different kinds of substances. Regarding opiate use specifically, the most common barrier for unmet treatment was a lack of financial resources. About half of people reported that, followed by a negative opinion of the treatment. So what should we make of all of this? So in this national annual survey, it was found that 1 in 10 adults with substance use disorder received treatment. And this study found important differences between men and women with those requirements. Most notably, the larger proportion of women that required treatment for opioid use disorder specifically reflects that the gender patterns are evolving over the last few years with the overdose crisis in our country. Despite the increased focus on substance use disorder among medicine in the recent past, the unmet need of treatment is still unacceptably high. Reasons for this public health concern are most likely multivariate and span societal and systemic factors. This study found that expressing the need for SUD treatment was not associated with actually receiving treatment. This shows that these common small screenings that we often do that are easy of identifying the diagnosis and then moving on from there is really not enough. We need to have multi-level clinical environments that we can actually intervene in this. It's not going to cut it just to say this person has SUD treatment or SUD and move on from there. We have to get these people plugged in. The primary objective of the study highlighted important gender differences in the ongoing overdose crisis. While more men experienced opioid use disorder, a larger proportion of women required treatment for OUD. These findings echo the changing pattern in epidemiology as the drug-related deaths have been rapidly increasing in women more than men. In the past, services that were specifically tailored to women, such as women's groups and childcare offerings, were deemed unnecessary, but this paper really kind of argues against that it's time that we have gender-based approach in our treatment. Alcohol use disorder was not the focus of this paper, but it did reveal some concerning disparities. As with opioid use, men were found to be more likely to be suffering from alcohol use disorder, but women were much less likely to receive treatment for alcohol use disorder compared to men. And this is kind of particularly concerning for me as a future obstetrician, considering the teratogenic effects in women of childbearing age that are consuming large amounts of alcohol. So the study did not discover significant differences difference by gender in overall receipt of substance use disorder treatment, but did find a lot of ethnic inequalities in SUD treatment need. Most notably, Latinx women and non-Latinx Black adults were much less likely than their white counterparts to receive treatment. This is consistent with other literature that shows that Latinx and Black populations are more likely to present to healthcare systems with greater addiction severity, and they have lower odds of initiating treatment for SUD. This paper argues that this most likely is due to systemic discrimination that is sadly very widespread in our country that affects income, education, employment, so on. Other literature also suggests that the stigma associated with SUD treatment is particularly prevalent in communities of color. Here, the paper reemphasizes the statement from the American Society for Addiction Medicine, saying that public health efforts should really prioritize racial injustice through community partnership and multi-level intervention. Finally, the study found that women disproportionately expressed a negative opinion about SUD treatment and concern about stigma and how it may affect their personal and professional lives. The paper argues that these attitudinal barriers may be driven by the stigma of SUD and treatment that's unfortunately very pervasive throughout our country and throughout our healthcare system as well. Women tend to be more susceptible to the stigma compared to men for a number of reasons, and it may help to explain the disparity that women receive treatment for SUD at a much lower rate than men. Future efforts to close this gap should include educational components to lessen the stigma at a national level. And the paper does reference one study that actually did show that people with opioid use disorder specifically were less likely to report a negative opinion about treatment compared to people with other substance use disorders, hopefully due to some recent public health efforts to destigmatize methadone and Suboxone. So I do admit that I'm a newcomer, I'm a newbie when it comes to addiction medicine. I think, unfortunately, a lot of my ideas about addiction medicine were probably formed by what I see in the media. And I'm already seeing a lot of those beliefs that I had being challenged within my 1 week experience that I have of addiction medicine under my belt. So I wanted to make a couple points here about things that really surprised me as I read through this paper. They may not surprise you guys having more experience in the field, but I thought that they were interesting to mention. First, I was really surprised by the age distribution of the population with SUD. Having studied epidemiology of disease in the past 3 years of med school, I would have assumed that SUD would disproportionately affect different ages, but that does not appear to be so. This was very equally weighted throughout all of these age groups, ages 18 to 25, and so on. About a quarter of the respondents fell into each one of these. So I was very surprised to find out that this is something affecting everybody, not just young people or elderly people or anywhere in between. Second, I was really struck by the prevalence of SUD among the wealthiest in our country. In the United States, the median household income in 2020 was about $67,000, which falls into this third category, which is actually the lowest category suffering from SUD. We see a tremendous amount of people that are wealthier than average that are suffering from SUD, and also in the below average category. But then we also see that, at least among men, the people that have the smallest amount of income are the ones that are more likely to receive treatment. and not what I would assume would be the people that have more resources to find treatment by having more money. So I'm really curious by this, and I wonder what future research and what the literature says elsewhere about what it is about having excess income that makes people less likely to have treatment for SUD. Maybe it's cultural or people that kind of glorify that lifestyle, but I don't understand. That baffled me a little bit. So the paper did mention several limitations for the study. I'll mention quick. First, the NSDUH, that survey was unable to incorporate populations that were incarcerated, institutionalized, or experiencing homelessness. And this may be a population that disproportionately experiences SUD. And there's potentially a lot of lost data within that group since we can't gather data on them through this survey. Second, this is self-reported data from a survey that most people take at home. So it's tough to know how accurately most people respond to that. Third, and related to that self-reported data, there's no way of knowing if the data on SUD treatment need and receipt was reported evenly across all racial and gender groups. Fourth, as I mentioned briefly earlier, the NSDUH does not assess sex and gender as two separate variables and does not have a comprehensive definition of gender. So the study was not able to analyze any populations that may identify as transgender or gender nonconforming, which we also know from other studies has an increased risk for SUD and unmet SUD treatment needs. So that was another disparity with this study. Fifth, the outcome of SUD treatment assessed location of treatment as either a specialty clinic or other, which greatly limited the respondents' options for people actually receiving their care. It also did not gather the type of treatment, whether it was medical-based or behavior-based, and it did not measure the length of treatment either. And lastly, this was a cross-sectional study, so the data that reported is associational and does not really help us point to causation. So in conclusion, there remains a very large disparity in receipt of SUD treatment, despite the increased attention focused on SUD treatment during the opioid crisis in the last number of years. With only 1 in 10 people with SUD receiving proper treatment, the rate of those receiving appropriate care is unacceptably low. As the opioid epidemic continues on, the epidemiology of the crisis is evolving as women and people of minority are disproportionately being affected and are experiencing more severe addiction while having less access to evidence-based treatment. So future public health efforts should use data from the NSDUH to appropriately cater these interventions to address a lot of these disparities that we discussed tonight. And that is all I've prepared for you guys. So thank you for your attention. I appreciate it. I'd like to open it up to your comments and questions, and hopefully you guys with some more experience than me can help guide this as well.
I have a question. Great talk. So one of your conclusions, and you've stated this several times, that women suffer from higher rates of SUD than men do. Was there a control for, say, mental illness, depression, fibromyalgia? There's some diseases where pain is heightened. So was that control for, or I just kind of wanted to know that, sorry.
I think since this was mainly a discussion on or a study on the demographics and self-reported surveys, there was a huge increase in women that reported psychiatric comorbidities. I don't believe that fibromyalgia was one of the variables also included in that, but I would imagine that that would go along with those disease processes as well.
It's a good question, Phoebe. The NISTA doesn't get at a lot of the medical stuff like comorbidities as well. But what you just said is very true in a lot of other clinical studies, that at least in treatment seeking populations, when people show up to treatment, women generally have a higher prevalence of both medical and psychiatric comorbidities. If you look at men versus women, at least for opioid use disorder, and some other substance use disorders have found the same too. So by the time they make it to treatment, they look worse than men a lot of the time. on a group level. But looking at this paper didn't look at odds of having a substance use disorder. It just looked at, we just did the regression for getting treatment.
I also had another question. Something came to mind because Sam, you mentioned that a lot of this SUD is not related to, say, illicit drug use, even though it is there, like it's not heroin or it's not like, taking street drugs that are opioids, but it's more related to, say, taking opioids for longer periods of time, then you end up being diagnosed with OUD, right? So in that case, is there also like the possibility that some of these participants aren't treated well, like those poor pain treatment in the beginning, so they were just not managed well, I guess. I don't know if it's even leading to some of your conclusions, but I'm just really fetching here.
I think I'm a little confused by your question.
Maybe I misunderstood what you said. So I think you said that a lot of the participants, they were not SUDs because of, say, heroin, taking illicit drugs. Of course, there is a subpopulation within the group, but then like say someone had back pain and they've just been taking narcotics for like long periods of time, right? So I'm wondering if a lot of it is just because their pain was poorly managed to begin with. I mean, it's kind of going back to the whole pain thing, but
yeah, that is an excellent question. I think that could be another limitation of this survey of I don't know if that was a captured variable of what led you to use these substances in the first place. We do know that a lot more people are taking pain medications and are using heroin, and that certainly could be due to poorly managed care or pain in the very first place. It's like 4 times as many people using pain medications than using heroin. And I would make a guess towards that would probably be started potentially in healthcare than people starting to take Oxy at home or on the streets.
thank you.
Sam did point out the finding in the text, which was among the subgroup, the small subgroup with opioid use disorder, so with the diagnosis of a use disorder, if you looked at the proportion that their primary opioid that of problematic use was either prescription opioids versus heroin, they don't assess fentanyl in NISDA yet. The prescription opioids were more common in women than men, and that's pretty consistent with other studies too. Now, I have no idea what it looks like today, because now it's today is a whole new day than 2 years ago, even when the end of the NISDA period was used for this paper because of fentanyl and all of that. But historically, the prescription opioid misuse and use disorder has been more common if you look at people with opioid use disorder in women than in men. Because of what you're saying, Phoebe, the chronic pain disorders, which can be more common. Certain chronic pain disorders are more common in women than men. And then there's some data looking to see that opioid prescriptions from medical providers, those patterns differ between men and women patients. Yeah, there's a lot going on there. Bhushan is working on an analysis of a paper with Annabeth on that right now. So, two more to come.
Thank you, Dr. Martin.
I actually had a question as well. My internet has been a little bit glitchy tonight, so I hope you can hear me, and I'm sorry if it breaks up. So you mentioned some of the tailored services that are being offered, like childcare for women, as well as like women recovery groups. And then you also mentioned several limitations to seeking treatment. And so I just wondered if through sort of that, your investigation of the limitations to seeking treatment, if you had thought of any additional tailored services that might be beneficial through your looking at the study or even through your experiences with clinical rotations at VCU, if there's anything that you've noticed that sort of limits patients that, you know, could be targeted in terms of a tailored approach.
Sure. I think probably for a lot of people's first knee-jerk reaction to catering responses towards women does go along with pregnancy and childcare and things, because women are parenting at a much higher rate than men are. But the other large disparity was that transportation piece, that women were disproportionately more complaining that I can't get my treatment because I can't get there. And I think that makes this particularly difficult. We know that like group classes work really well for certain disorders and for a lot of grief counseling and things of that sort. But this is a little bit of a disorder where I think people would be more prone to not admitting that and wanting to have group care. But certainly if people are willing, then group care may be an option. I don't have too much experience, and I have about 3 half days of clinic under my belt. So I think that's a great question. I'd like to learn more about that as well.
Thank you.
Margie, you're muted. Oh, I knew she was going to have comments about that. Your question, Brenna.
So how do I?
You can just.
Oh, I can hear you.
Now she can hear.
Oh, you can hear me now? Oh,
Yeah.
Okay. I was going to say, I mean, when you think about the services for women in particular and parenting women, for years, we've had it so people could go to exercise. They get there, they drop off their kids, they have all these little activities, you go with your baby, just so you can swim. And we don't have these types, we recognize that, right? That industry has recognized that forever. And here the healthcare industry hasn't recognized that. So that drives me up the wall. The other piece I would like to say is, as far as transportation goes, there are, they have that problem with the transportation. And with COVID, it's made it a little bit worse because even the bus systems will allow people to ride them for free here, which will great. People will say they're afraid to use the bus system because with COVID. Medicaid is on the right track. They have that transportation line that our moms can use. However, they too have to have some organization, and as a business, they need drivers. And like all the other agencies today, because of COVID, they're down workers. So, it's our women might be picked up. So sometimes they're doing everything they can, they're making that reservation. But I think moving forward, because COVID coming out and we're coming into our new norm, hopefully, not just Medicaid, but even commercial insurers will be able to provide transportation and reliable transportation. Because I think that's the only issue right now with Medicaid is they I think are doing the best they can with the limited amount of people that they have as well. So there's a little stigma around taking the Medicaid taxis, and I have had patients flat out refuse for me to even make the reservations for them. But most of the moms are very happy to take the transportation.
Thank you, Margie. I wonder sometimes with all the transportation and those types of barriers that we see. I always wonder, because I've never worked in a rural setting as an addiction medicine provider, but I've wondered, what if we were in Western, more rural Virginia? What would this conversation look like? And sometimes I wonder about that. I don't have plans to move to a rural area. I like being in my suburban urban area for personal reasons. But I'm curious sometimes. I think it's about the same probably. Like my colleagues I talk to at conferences, like we say the same things, they just sound a little different, right? And then you see this national level data, and it's national level data, right? And we're seeing those findings that you pointed out, Sam, of the barriers. So I think sometimes sometimes I have to check myself and I assume things are going to be so different, but then when I talk to someone else who has a similar job to me, I quickly realize we're all doing the same thing. It just might look a little different depending on where geographically we're working.
I also think, Sam, you brought up such a good point. Can you hear me? Sam, when you brought up, that it's not enough just to do the screen, right? That's not enough. And so the fact is, we are going to have people that, even if they want to come to us, they can't get to us because it's too cumbersome. So we need everybody, all the little satellite groups, even if they're not the main group, we need everybody to do a little bit more. So, I know for doctors out there in the EDs and so forth, just getting their X waiver, just being able to like tide people through until they can come up with that plan. Even that more than, and then we can call, and get them that appointment right away. But I think it would be great if a little bit more could be done in all little satellite areas. That would be wonderful.
We talk a lot in medical school about those kinds of things of, having the right question to ask and screening for intimate personal IPV, intimate partner violence, screening every single patient for depression and suicidal thoughts. And we spend so much time talking about screening for these things that it makes me a little bit afraid for the time that the person says, actually, yes, I am experiencing that. And then, oh no, what do I do as a provider now? I thought that's as far as my med student brain went, was asking the question. Now I need to respond to it. So I hope that I get there more in residency. I think that'll help me, but I think I've really been grateful for the things that you guys have taught me of realizing like, this is something that is a disease process that we can overcome. And, now I do have an idea of what to do when I screen for that and they say yes. And then now I know how to help instead of just diagnosing that and helping them, giving them a piece of paper to go to a group for it.
Well, thank you, Sam. We're reaching our end of our time, and I feel like that was perfect, the way that you ended that discussion. And so the take-home point is, we need more providers, and we need more people in all different specialties and different professionals across different areas to be able to not be afraid to ask the question, like what you just said. Because screening doesn't even happen. I know that's just step one, but it doesn't even happen because people are scared to ask questions. Providers get scared to ask questions about things that we're not comfortable with, right? It's just like pregnancy. People a lot of times are scared about pregnancy, so they just don't ask about it. And so we're hoping that, through the clinical rotation you're on, as well as, through all the collaborations with OB Motivate that Margie and I work on, and then also the collaborations with the lab to help equip the medical providers to not be afraid, right? So it does bring me joy whenever I get a text from a resident, who's out in practice, and they might not know exactly who to send, how to get that patient there, but you know what? They asked the question and they did something about it, and they at least called me, right? And then they did. So it's, we have a long ways to go to make things even better, but there's a lot of things to be done. And so, and if you're in the research realm, the things that we use, we need to keep on testing different modalities to prepare different professionals and build the research base and the evidence base for treatments. So we can, put ourselves out there, because you don't change policies and you don't change clinical care until you have the research to back it up most of the time. So as a motivating note, thank you, Sam. I appreciate it. Okay, well, it's now 7 o'clock, so I'm going to send everyone away, but thank you so much for sticking in with us at the end of our Journal Club, and reach out to me or Bouchon if you need anything, and we'll see you guys next month. Bye.
Dr. Martin, could you stay on for 1 second,